We carried out a research project in which we wanted to find out what is helpful and what gets in the way of looking after our oral health when life is complicated by severe mental illness, like psychosis, bipolar affective disorder, or severe depression. As part of this research project, we also wanted to find out what type of oral health interventions are likely to be engaging and effective. We asked people living with severe mental illness, their families, carers, and the professionals who support them about their thoughts and experiences on the subject of oral health to help us design better interventions. Service users with severe mental illness felt that oral health education to gain better knowledge was an important ingredient of interventions. Toothbrushing demonstrations were also considered helpful. However, a patronising attitude and information overload were identified as significant barriers to engaging with such interventions. Provision of toothbrushes was thought to have the potential to increase motivation for regular toothbrushing. Practical help, such as reminder texts or calls for positive reinforcement, or use of reminder techniques and record keeping, such as use of toothbrushing activity calendars or keeping a diary, should be tailored to the needs and preferences of an individual. Involvement of carers, including family and friends or paid professionals, can also be helpful in facilitating behaviours that lead to good oral health. Carers can boost motivation to look after teeth and maintaining oral hygiene by offering reminders for toothbrushing or accompanying visiting a dentist, especially in case of anxiety to visiting a dentist. One of the biggest barriers to good oral health is inability to access a dentist for routine dental checkups and treatment, or long waiting lists. The dental care system is complex and costly. The commissioning system and high staff turnover is a barrier to the provision of timely dental care. Service users with mental health problems need to meet a certain threshold of illness severity before they are referred to community dental services. Failing to meet this threshold leaves them with the only option of utilising the services of a high street dentist. However, consecutive missed appointments due to difficulties in day-to-day functioning can result in them being removed from a dental surgery's patient list. Mental health nurses incorporating an oral health checklist as part of a patient's routine physical health checks can be a facilitator, but only when further practical support, such as finding a dentist, setting up an appointment, help with visiting a dentist and navigating the NHS dental cost system could be provided, rather than just ticking boxes on a checklist. Service users consider mental health nurses to be in a good position to initiate conversations around oral health, as they usually have rapport and a trusting relationship with them. Also, by involving service users and carers in the care planning process, which is led by mental health nurses or care coordinators, oral health can be included in routine care plans. However, there are concerns related to capacity and willingness of mental health nurses to be involved in provision of oral health support, as most of the services are stretched to the limit due to heavy caseloads and high staff turnovers. An integrated care model can be the way forward. This means including dental personnel, like dental nurses or dental hygienists, in a mental health care setting for conducting a basic checkup, offering oral health education, referring a service user to a dentist as needed. Following that, providing tailored support in collaboration with care coordinators or mental health nurses. This model was identified by service users as the best kind of care that can be offered to people with severe mental illness for their oral health needs. Health professionals who are involved in mental health, oral health, and physical health care need to work together with proper communication channels between various services and with the service user to optimise their oral health care. Lack of training of staff involved in provision of care to people with severe mental illness was identified as a barrier. Both dental and mental health service providers agree that there is a need for training staff in ways that they communicate with their patients regarding oral health and mental illness. These include training in softer communication skills and in providing more information around possible side effects of antipsychotic medications on oral health. In conclusion, oral health is an important part of our general health and well-being. Practical help tailored to the individual, service user and carer involvement in care planning, integrated dental and mental health services, and staff training could facilitate better oral health for people whose life and well-being are affected by severe mental illness.